So the emphasis on, oh, that does make a difference. So the emphasis on future is really important. So we're not necessarily talking about the feedback that may happen in context of a clinical setting in the OR where immediate information needs to be given from the attending to the resident, because if the resident doesn't get that information, something untoward might happen. That's, you know, sort of corrective or information giving. But we're talking about feedback that occurs usually later than the performance in the clinical setting, and it is really future oriented. It's for the purpose of making that person better, for helping that learner to achieve their goals for learning better and more achievable through feedback. So that's what we're talking about today. And I also want to situate feedback in the larger context of teaching. So feedback isn't all of teaching, it's just a component, but it's an important component. But as you see, there are other components as well, and all of those work together to form good teaching. So that's all foundational. So my background is in sociology of medicine, and when I first started my graduate work, I had this naive notion that that feedback actually occurred in apprentice types of relationships. I had the romantic notion that medical school and residency was an apprenticeship, which to a large extent it still is. But I had the notion of the model of the, you know, the master and the resident working together continually. But in early on reading Jack Endy, realized that that longitudinal relationship isn't necessarily built into medical education. It is to some extent, but not in the way that it used to be built in that old romantic, you know, apprenticeship model. So, and that's what I think Jack Endy recognized when he recognized the feedback wasn't occurring well in his residency program. So he first he looked at some of the communication literature to learn, you know, how might we make this communication better, and wasn't finding all too much in the communication literature. So then he went to rocket science and thought, this is a pretty good model. This is what I mean. This is exactly what I mean by continual feedback that needs to occur in residency. So why rocket science? So in the 50s and 60s, the literature that he was reading about rocket science at that time in '83, we were sending up lots of rocket ships. But they weren't as advanced as they are today. So we would send them up, the engineers would send them up, but only with a small notion of where that rocket ship was going to end up in the next few minutes or in the next few hours. So the idea was that the communication between the rockets that's now out there and the engineers who are on the ground had to be continual and iterative. So the rocket would send back information about what it was doing, where it was, how on or off course it was. And the engineers would take that information, process it quickly, send information back to the rocket. It would adjust, and then more information back to the engineers, more processing, more information back. It was an iterative process until the rocket got exactly on the course that the engineers hoped it or wanted it to be on. That's the kind of feedback, that's the model that Jack wanted to build into the communication in residency, continual and iterative feedback. So looking at this is based on Jack's, but this is mine. So looking at the education system, medical education, and the broader education system in the West, to a large extent, the system of evaluation feedback has been based on this very linear model. So starting with the system that gives out some information to the learners in this case, there's performance that happens. Usually that performance is a test in, you know, secondary education and higher education. And then there are results at the end of that performance, and that's the feedback that the learner gets at that point. Very linear. But what's the problem with that in terms of concept of learning. Anybody? Problems? You can't adjust midway. The test may come too late, and then you may not have the ability to get more information that's corrective. So a lot of us have, if not all of us, have learned that way, right? So the best thing we could do at the end of the test, if you got a C, is to go back to the material and try to learn it, but there was no one else retesting us, so we were kind of on our own. And that is pretty much how education has been designed in the West for a long time. So what Jack wanted to do with this iterative and continual feedback is to give information, watch some performance, observe performance, give feedback on the results, and make that an iterative process. And then eventually, there's the test and the summative results. So both of these are important. Because we do want to do this because it is our duty to send out doctors who are prepared. It's our responsibility to society to do that. Very important, but only after a lot of information has occurred in an iterative fashion. So I would say that, you know, at this level, this is the role of the residency directors, of the clerkship directors. John is a residency director in primary care. He is left with this task of evaluating, of being summative, of making sure that we're sending people out who are prepared. I see the iterative and continual communication, the responsibility of all of us, and probably less the responsibility of John, although he does that some. But his concern is sending people out who are prepared. The rest of the educators' concern should be making sure that that person gets better, or that that class gets better, that they're prepared to take the next step. So it's not so summative, it's formative. So let me call on you one more time to have you think about what makes constructive feedback. So if the process needs to be continual and iterative, what is it that makes it constructive in that continual conversation? You want to take a guess at some characteristics? Objective, so something that's observed as you stand back a little bit. You can put some subjective interpretation into it, but yes, objective, observed, not getting too involved in the performance while it's happening so that you could stand back as the teacher and observe the performance. So that's a good one. One more, and then I'll give you the rest. It's specific. That's a great one. So who said specific? Great one. So this is one of the things that is violated the most, and you'll recognize this. Feedback very often is, great job with that patient, great job with that procedure, good presentation. You know, maybe read a little bit more in this area, but it was a great presentation. So the maybe read a little bit more is a bit constructive, so you're getting there, but it's usually very general. And even when there's some corrective information that's given, that corrective information is too general too. So read a little more about X is okay, but maybe some even more specific information about what X is, or what part of X the person needs to focus on. So it needs to be more specific than we generally build into our feedback. So these are, I'm going to put them all up, and we're going to deal with these much more on Monday and talk about why they're very important on Monday. But I just want to talk about a couple of them. So specific, we've talked about. Behavior-based is very important. Who thinks that you can give feedback on attitudes? A couple of you. I actually think you can, but I think that's not the starting point in giving feedback. I think the starting point is reporting what you observed as the observer, as the teacher. And the problem with starting with things like attitude or values or personality traits, which I'm not sure, personality traits is a touchy one. I'm not sure that we ever get into that, though there may be times that you need to. But the problem with starting with any of those is that we can make assumptions. You don't see attitudes. You can assume that some behavior, that there's attitudes underneath some behavior, but you can't really see what the attitude is. So the example that I use always is, I have a person who works, this is hypothetical, who works at the Teaching and Learning Center. We are above the Child Study Center and the Daycare Center. We have a person who works at the TLC who has a child downstairs, again, hypothetical, who's late for noon meeting every meeting. So I could call that person in and say, you know, do you not value the noon meetings? I mean, we think that they're really important, and it seems to me that you're not really valuing them if you arrive late. That's an assumption. That's not an observation of behavior. It is that you arrive late is an observation of behavior, but the rest of it is an assumption about an attitude or a value. So it's different if I start the conversation with, so I noticed that you've been late the last 3 meetings. Is there anything that I need to know, or is there anything going on that we can actually work on together to change it so that you can be there on time? And that conversation could lead to the fact that she has a child downstairs who takes medication, has to have it at noon, it's refrigerated. So she wants to make sure it stays refrigerated, and she takes it down to the Child Study Center and gives it to her child at noon, and then arrives 10 or 15 minutes late for the meeting. So there's still a feedback conversation that needs to happen, but we can work out, maybe you can go down early. Maybe you should allow the child study staff to do it. They're perfectly capable and they do this all the time. Or maybe we can start our meeting 15 minutes late if you want some time with your child midday. Like, all of those are good options. But that's a constructive conversation that can come out of first reporting the behavior that isn't good for the group, that needs to change somehow. And then we work on some solutions. So that's why behavior-based is really important as a starting point. The other one that I want to talk about, and the rest we'll leave for Monday, is direct observation. And you said this already, that it's important that feedback is, that performance is directly observed, because you have the ability, you have the authority to say what you observed in that performance if it's directly observed. If it's secondhand, I heard that, you know, others have told me that this performance occurred, then the comeback can always be, yeah, but you weren't there. And this is, from my perspective, this is actually what occurred in that performance. And I'm sure, I mean, I know that happens a lot. So direct observation is the way around that conversation that isn't as fruitful. But I also realize that direct observation isn't always possible. Again, I'm going to use John as the example, because as a program director, impossible for him to directly observe every performance, or even some performance of every primary care resident. So a lot of the feedback that he gives is based on secondhand information. Again, I think if we shift the responsibility of this iterative feedback more to all of the teachers, he has to do that less and can actually focus on the summative. But he has to do some of the formative feedback. So if you're in that position, you don't have the ability to directly observe, I think what works is if you can get secondhand information from maybe 2 or 3 or 4, it's like qualitative research. If some of you have done qualitative research, you listen to and you collect the narratives as many of the stakeholders as you can. And when you start to hear saturation, you know that you're seeing something that's based in some fact or some truth. So if you start hearing the same thing over and over, that validates the idea that something has happened in that performance. So collecting, information from a number of stakeholders and a variety of stakeholders is a good way around that. Again, we'll talk much more on Monday. So given these characteristics, this is how we're defining feedback for today. It's well-intended, timely, specific, and manageable communication about performance or behavior observed by the feedback giver so the receiver can enhance that future performance. So with that, I think we'd like to role play first. You want me to do this? Okay. So a model. Again, we'll get into the model more on Monday, and we'll actually have some time to role play it in pairs so that you can practice the model. This is not the only model for giving feedback. It is a model. There are others that we might talk about on Monday, but this is one that we have found to be effective and could be adjusted for the quick 1-minute, 2-minute feedback that usually is the situation where you only have time for. So we want to start with G and O, the go and the go, ask, tell model. And these we have talked about already. So the G is goal setting. We didn't talk about this in depth. So it's that first characteristic that I had on my list where feedback, constructive feedback, should be based on mutual goals. So a time in which maybe at the beginning of a rotation or at the beginning of the day, there's a quick conversation about what I, as the teacher, would like to see you work on, because I have the bigger picture. And you know, I know that there are some things that you can work on or that you all need to work on. And what are some specific things that you, as the learner, may want to work on today or in this rotation? So reaching some mutual goals is the first step. And then the goals that you've reached together are the basis of what you're actually going to observe. So then you're going to observe the fact that you're going to work on communication better today, or you're going to work on a procedure differently today. So that's the G and the O, the observed performance. And the ask, tell, ask is actually the feedback conversation that happens later after the performance. So what I like in starting feedback conversations is starting with a question rather than giving feedback points. So the first is, in the model, is the ask. So how did it go today? So we talked about doing something a little different on this procedure. How do you think it went? Do you think you incorporated the things we talked about? So starting with the question, getting the reflection of the learner. Why this is good is that it allows you to, as the teacher, well, the first thing is that it may get you off the hook, because if the learner says the things that need to be corrected and is aware of that already, you as a teacher don't have to put that on the table. Then you can start the conversation with, yes, I agree, and let's talk about some ways that that could be different, which is the tell. The other reason why it's a good idea to start with the ask is it gives us as teachers the ability to see, to observe how well the learner self-assesses. There is a literature on this. I'm forgetting his name offhand. But anyway, I'm sorry, Kevin Eva has actually studied this, and we know from his studies that we are all of us are not great self-assessors, but we do get better over time. So the further on you go in your training and in your practice, the better we get at self-assessment. But we all have some blind spots that we're not aware of. You see my performance better than I see my performance. I might watch the video later, and then I can self-assess based on what I see in the video. But I can't really self-assess very well as I'm doing this. I'm concentrating on doing this, right? So we're all relatively bad, and early learners are particularly bad. So if in the ask, you find that the self-assessment is way off target, then you have the ability to correct that perception or those perceptions. And that's another piece of giving feedback. Maybe the first step is actually helping to correct perceptions before you get into the specifics of what needs to be changed to perfect that future performance. So that's why I like ask. The tell is the responding to the assessment, and that's iterative. There can be a series of asks and tells in the conversation. And the last ask is ending the conversation with another question. So what are you taking away from this discussion? What are your next steps? how might I help? The thing that I like too about this model is that it is based on relationship and it invites relationship. So particularly with the last ask, you're saying, how might I help? What can we do together to take the next steps? That involves a relationship. That involves having to talk to each other more than one time about whatever it is the feedback is constructed around. Now, I do realize that all of us don't have the ability where it's impossible to develop a deep mentoring relationship with every learner. So I think you have to adjust this based on how much time you can put into any individual learner. But the next step doesn't necessarily have to be come back to me and then we'll work on it, particularly if you're giving feedback on a rotation and that person's going to another rotation tomorrow. But that conversation can end with, what do you think your next steps are in this area? And I think it would be a good idea if you take that awareness that you just gave to the next rotation and find somebody who can actually continue to help you with that area. So it doesn't have to be a relationship that you are always part of, but I think leaving with some next steps is important. So now, forgive us if we're going to just demonstrate a very quick role play. And forgive us if we pay attention too much to our script because we haven't done this particular one for a while.
We haven't done this ever.
Oh, that's true, ever.
It's brand new. All right, so for the purpose of this interaction, I am actually the attending, and John is going to play the role of the resident. And what I want you to do is, as we're kind of moving through this framework, is think about how this kind of fits the model. And then we'll have a couple-minute debrief about your thoughts about the experience after. All right, so John, how are you?
I'm good.
You know, I know it's the first day of the rotation. We're pretty early on in the academic year, but I was hoping this would be a good time to talk about some goals for our 2 weeks together on the service.
That'd be great.
Anything you'd like to work with?
Well, I've been thinking about and trying to work on my last rotation on communicating better with patients. So maybe communication skills.
Could you be a little more specific about what kind of communication skills you might want to work on?
Well, I find that I actually think I focus a little bit too much on the medicine, which is important. But while I'm thinking about things that have to do with the treatment and the medicine, there are things that the patient, I'm not always aware of what's going on with the patient. So there may be some questions, things that they're not understanding. So I want to kind of be able to break away from just focusing on medicine and give some time to the patients, answer their questions. I don't think I give that much time to that.
Well, I think that's a really valuable goal because I think how we communicate with our patients is really important. A couple of things to think about in that context. One is obviously, in the conversation itself, in my experience, one of the challenges with effective communication is really trying to avoid jargon. So one of the things that I would like to see is, you trying to minimize your technical jargon in those conversations.
So you've seen me use jargon?
Well, I mean, we're just starting together on the rotation. So it's something I'm going to be sort of looking for and to be mindful of. And then I think the other piece is the time pressure piece, right? So we're going to be rounding. We got to get to the OR. So your presentations, the shorter, crisper your presentations are, the more quickly you get to your differential diagnosis in your plan, the more time we'll have to deal with the patient education and the communication. So I'd really like you also to be working on crisp presentations, short differentials, and moving forward. Does that sound okay?
Yeah, it sounds great. And I do think that getting to the point faster has been an issue for me too. I guess that's part of what I was talking about in terms of focusing too much on medicine and in the differential. I sort of go through all the possibilities. So.
All right. So we'll try to do some targeted observations on those two specific skills, really kind of the patient communication, the presentation, and the differential, so that we can work together on those skills. All right, so natural break, right? We just did everybody see the goals. Now, obviously, we're not going to go and do an observation here. We're going to assume that the observation occurred. And now John and I are going to jump back in to the ask, tell, ask version. So John, is now a good time to sit down and have a conversation about how things have been going? Do you remember those goals that we talked about earlier?
Yeah, so we talked about not using jargon and getting to the differential more quickly.
Okay, good. So how do you think those have been going for you?
Well, I think it's gone pretty well. I mean, I don't actually think jargon is much of an issue for me, so I haven't been aware of using too much jargon in front of patients. So I think that's okay. I do think that I am having a hard time sort of getting to the differential quickly.
Mm-hmm.
I'm just tend to be more reflective, and I just think through all the possibilities. And I know I probably say too much, in front of the patient. So I'm not sure I've arrived there yet.
Okay.
I've noticed that my peers do that better than I do.
Yeah, from my observations, I actually haven't seen any jargon. I actually think your patient communication skills have been great. You've been involving family members. You've really been taking the time, listening to their concerns, asking the questions, and absolutely no jargon. So really nice job on being thoughtful about that skill. I think it's interesting that you're reflecting on how you're feeling in relation to your peers. Do you want to tell me a little bit about that?
Well, I mean, I just think your goal for me was to get to the differential quicker, and they just have the ability to do that. And I just
Mhm.
kind of envy that, because it's hard for me to let go of some possibilities. So, I don't want to take some things off the table to get to a quick differential. And I notice they do that better than I do.
So I think it's good that you're aware of that. And again, I think one of the goals that we set was really to enhance patient communication. So one of the observations I had is that when you're talking to the patient and you're presenting, 5 possibilities about what could be going on here, although you're avoiding jargon, you might actually be causing some confusion on the point of the patient because they're not sure which of those 5 is really important. So I think as it relates to the presentations and the differentials, I'd really like to see you moving forward, really kind of come in with what you think is the most likely and present that option to the patient. And then as you're presenting, the data that you're going to bring in is really going to be related to that problem. And, I think that's something that your peers are probably doing. And they're probably also thinking about the broad differentials. So, because you don't exactly know what's going on in their heads. So I wouldn't worry less about that. Just try to work on the action of let's put the 1 or 2 major problems on the table and really kind of move forward. And I think that will also continue to enhance your communication skills. Does that sound like a good plan?
Yeah.
Okay.
I'll work on
Okay. All right. All right. Thoughts about that model?
How do you feel about the length of time that it's unrealistic to have that much time?
About 5 minutes, right?
It does seem a bit unrealistic to me, maybe, and I think my first impression of it, gut reflex, that this, in the context of surgery, I feel like those doesn't happen, that might be challenging. Well, it could. I mean, I'm trying to think about an objective reason why it couldn't happen. It seems that it does not.
I think part of it is this is a model, right? And I think if you're thinking about a model, models are great, but you don't always have to use the model, right? So, and one thing that I want you to take home is if you observe something that needs to be corrected, but you didn't sit down and have a discussion about goals, and that's not on your goal sheet, doesn't mean you can't correct it. I think it's important to correct it, and important to correct it in the real time. Otherwise, that learner might be thinking that behavior should be reinforced and is okay. So yes, I know it can be understandably a little bit challenging. I mean, it can be very, you know, dependent. So say you're working in clinic, right? Busy clinic, seeing lots of patients, right? You're going to go in with a resident and say, you know, I'm really going to evaluate how you're evaluating this symptom, this patient's obstructive voiding symptoms, and give you some feedback. Really quick goal right before we go in the room, you let your resident know what it is that they might want to focus on, and then you have the opportunity after that visit to say, hey, how did that go? Here are my thoughts. And you can really crunch it down to a relatively time compressed moment. Yeah. Right, because you'd be in trouble. Yeah. Yeah. Right. Right. So that's a perfect segue into thinking about a tool, right? So the purpose of feedback is to change the individual's behavior, right? The purpose of the feedback is not for me to actually give the feedback and say, I can pat myself on the back and say, I gave feedback, great. The purpose is that that individual hears it, reflects on it, accepts it, hopefully, and incorporates that into future learning. So tools are great for helping that happen, but you do really need to think about the larger context of feedback as it relates to the learner, as it relates to your role as the teacher, and as it relates to the overall culture. Yeah. 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 That's great. Yep. Yep. Yeah. Yeah, and again, I think that the word intentional is an important part. Is this needs to be seen that it's something that is part of your job. So I know, Peter, if we think about the traditional feedback paradigm, it's really all about the teacher, right? You know, and the teacher has immense psychological size, is the one who's guiding all the observations, makes the goals, and sees what they see, and slams it down on the learner, and the learner may or may not accept that. And the other thing to remember is that this all occurs in a culture, right? And I think the larger challenge of thinking about applying the tool is thinking about what's the culture within this occurs. And because that's going to have a huge impact on whether or not that learner is, one, going to accept the feedback and grow from that feedback. What would be ideal is that the learner and the teacher really are actually on the same level, that they have shared common goals, and they're really working together to grow in a culture that really supports that. And for the next 10 minutes or so, I'm going to dive into some of the literature about teacher-related factors, learner-related factors, and culture that have an impact on feedback delivery and feedback assessment. So learners. So John already mentioned that learners don't self-assess well, right? So our goal, our ask, tell, ask, that first ask is a self-assessment. If they're not doing that well, and the literature would support that they're not doing that well, that's a little bit of a challenge. But I think this is a learned skill. And I think the other piece is you can actually do what's called informed self-assessment. So we were intentional about having this individual in this case be relating themselves to their peers, right? It's okay to relate yourself to your peers and use that as a self-calibration. Also in internal medicine, one of the things that we use as a self-assessment tool is the milestone. So where are you on your milestones? Because that's your trajectory for learning. And you can look at those milestones and say, you know what, as it relates to communication, I'm off here and actually enhance your self-assessment. We're not rocket ships, right? We don't just take that data in, accept that data that says I'm off course, and really correct, right? Somebody tells us we're off course, we go, oh man, how could I possibly off course? I have spent my whole life being great in medical school, being great in residency, winning all kinds of awards. There is no way that I am off course. So this feedback does not meet at all with my self-image. So I'm not going to accept it. So you do have to be mindful that learners have an inherent self-preservation, that they're not rocket ships, and that then therefore associated with that might be emotion, right? And one of the reasons why we often shy away from feedback, and in particular feedback which is particularly constructive, is that, oh my God, I'm going to make somebody cry, right? Because again, this doesn't jive with their self-image. So using that self-assessment part might help a little bit so you get a sense of where they are, but also be ready that if you're giving particular guided, constructive, specific feedback, that there might be emotion associated with it coming back towards you. And think about the orientation of the learner. This is probably more of an issue for students if you're working with students than if you're working with residents per se. But remember that students, if they are really performance oriented, meaning what do they care about? They care about that honors, right? So if all I care about is I got to get that honors on this rotation so that I can, get my sub-I and so I can get into my good residency, I'm not worried learning about the specific skill. I'm actually just worried about looking good in front of you. And that might be a little bit of a challenge as you're giving them targeted directed feedback, where maybe you've worked with a learner who just really cares about learning for the sake of learning, is really learning oriented and wants to learn the skill. That's great. We need to figure out how to shift people to that goal. And some of that involves the culture of your feedback as it relates to how it fits within the evaluation culture. And thinking also about what works for them. So they've all probably gotten a lot of feedback. Every learner is different. It's fair to ask a learner what works for you. I appreciate when my feedback is really direct. That's great. I can give you really direct feedback. Teachers, that's a big part of it. So, and Peter, this is your point, right? What's your personal experience with feedback? So when I was a resident, Rosemary Fisher was my program director. If you got called into the office, you were probably in trouble. And we went through residency with no news is good news. And that's the model of feedback that I grew up with. I suspect it's a model that a fair amount of those who've grown up with. So when I'm working with a learner, if I'm not saying anything, that means you're doing well. They're from a different generation, right? That is not their paradigm. Their paradigm may be they're expecting to get a lot of feedback, expecting to get it now, and expecting it to be specific and get it directly. So then we get a feedback mismatch. This work actually comes from work from Pelgrim, which is from the family practice literature, but it was interesting because they observed a bunch of outpatient attendings and residents interactions, and then looked specifically about what teacher-related factors were associated with positive feedback and increased amounts and effectiveness of feedback from the perceptions of the learner. And from the teacher things, two things came out. Task perception, is it your job? Is it your job? So if you thought it was your job to give feedback, guess what? You're more likely to give feedback. So it's your job. Helping trainees attain all of those goals, be good physicians, is your job. And then if you're neurotic, I thought this was really interesting. If they were neurotic about the patient care, guess what? You're in a family practice world, you're caring for my patient. So if you get it wrong and I'm really neurotic, I'm not going to let that happen. I'm going to correct that in real time. I think one of the biggest ones is the issue of credibility. So Christopher Watling, who is a psychologist, did a study where they actually looked at 22 junior faculty across all subspecialties and asked them to reflect back on feedback experiences that they had during their training and said, what made a difference? Most common in this study was patient feedback. The patient feedback had a high impact, they could remember it. And then bad outcomes. Faculty, teachers were a distant third. So should we then just give up and let our patients give all the feedback and let the outcomes speak to the outcomes? No, we probably shouldn't. couple things that came out of that study that were interesting that mattered is that the faculty members that people tended to remember the feedback from and listen to and incorporate were those that were credible. And to be credible had to be based on direct observation. You had to have clinical expertise. It also helped if you had shared aligned goals. So credibility matters. Credibility matters. So think about your direct observation, think about those skills. There's a lot of issues that relate to culture. What's the hierarchy in the institution as it relates to learning will have an impact on how feedback is expected and or accepted. What's the culture of autonomy? We're in the residency world, we're training residents to be independent practitioners, right? So maybe we should just step back and not give any feedback and let them figure it out on its own. Or what does that culture feel like in the world of urology? How much autonomy, therefore, how much feedback, and where do you find the right balance? How is feedback linked to evaluation? Although we're not necessarily talking primarily about students, residents still get evaluated, right? And evaluation sometimes, from the resident perspective, might not feel particularly good. And how is that individual formative feedback related to the evaluation, overall evaluation culture in the program? And then what are the defined expectations of the teachers and the learners in this setting? Is this an expectation that this is going to occur? Can they develop relationships? Will those relationships be mentoring and allow for that sort of natural space for positive feedback to occur? And then what's the culture around accepting criticism? Is it okay to accept that criticism? Take feedback as a gift. Feedback is a gift, we often say. Maybe not the gift that you wanted, but it's a gift, and you can use it to improve your performance. So again, I think as we're thinking about this paradigm, and I'll use this as my last slide, we're thinking about the learner and remembering that also this feedback occurs in an incredibly complex environment, right? So they're interacting with the patient, they're interacting with their clinical outcomes, and they're also interacting with their peers. And all of those are going to have an impact on their individual growth, and they're going to be dealing with that feedback. You also need to think about your role in there as a teacher. And then in order to enhance that feedback that becomes incorporated and accepted into new behavior, think about your role as a teacher in that environment and trying to be credible, which means thinking about direct observation, right? Thinking about your clinical credibility. You know, because if I start giving, as a general internist, start giving somebody feedback about their surgical technique, you gonna listen to me? No, I'm not gonna listen. You need to be credible and based it on direct observation. And I think from timing, we got to end right now. But again, I'm looking forward to working more with this model with everybody on Monday night. So thank you. There's a case. Yeah. So Monday night, we are actually going to get together and we're going to actually dig into the model with using some role plays. I mean, I know everybody's going to groan because you hate role plays, right? But we have created a bunch of different cases, and you're going to get to go through the model of giving feedback for the faculty and for the residents, some experience of giving feedback, but also some exercises on how to actually ask for feedback if you're not getting it. So that's the plan for Monday.
And on Monday, we'll also talk a little bit more about we're actually organizing a rock climbing trip. It's going to be 3/4 spot, but 1/4 thinking a little deeper about feedback, because there's a lot of feedback that happens in rock climbing, and what implications that, what clinical implications that might have. So talk about all of that on Monday. Thank you.
Should we just blanket?